next topic by Dr. Ahmed Abouelhoda about management of dural arteriovenous fistula.
Good morning, dear professors and colleagues. I would like to start by thanking Dr. Mustafa for a very unique presentation as usual. We'll talk very, very briefly about the dural AV fistulas. What's the dura itself? The dura is the tough mother of the brain, which is consisted mainly of two layers, the outer endosteal layer and the inner meningeal layer. Under the dura, there is the dural venous sinuses, which are endothelial-lined spaces between those aforementioned layers, which drains into the internal jugular veins, and we have the small emissionary veins and the cortical veins draining inside the dural venous sinuses. What differs the veins of the brain from the rest of the other brains of the body? That they have no muscular tissue, they lie in the subarachnoid space, and they drain in the cranial or the venous sinuses itself. A very quick look on the blood supply of the dura, which differs dramatically according to the place and the anatomical place of the dura, and the anterior cranial fossa from the ophthalmic and the ethmoidal branches, middle cranial fossa from the middle meningeal arteries and the ascending pharyngeal artery, and the posterior cranial fossa from the meningeal branches of the occipital and the vertebral arteries. What's a dural AV fistula? It's an abnormal connection between the arterial and the venous side of the vascular tree located on the surface of the aforementioned dura. What differs it from the AVM? The nidus of the AV shunting is solely contained within the dural leaflets, which distinguishes this from the pile AVM. As you can see here, the red circles, these are the abnormal connections, and this light blue arrow, this is the thrombosed veins or dural signs. The epidemiology of the dural fistula is 0.17 per 100,000 persons. It usually compromises 12% of all intracranial vascular malformations. Usually we see it single dural fistula, yet multiple fistulas can be presented in about 7 or 6.7 accurately percent. It's a multi-staged pathophysiology, starting with thrombosis. Here you can see thrombosis inside the veins, shifting the flow, okay, thrombosis, the enlargement and expansion of this pre-existing microshunts, leading to, here in image D, recanalization and diversion of the arterial flow into the cortical veins, ending in complete recanalization of the normal venous outflow with still reflux and expansion of those pre-existing shunts. Location of the dural fistula, the most common locations we have are the cavernous sinus and the transverse sigmoid sinus, which are more common found in the females. The superior sagittal and the anterior cranial fossa, more common in males. When we see the classification of the intracranial dural fistula, we have to think about three main factors: the direction of the flow, which is antegrade or retrograde or both, is the reflux in the subarachnoid flow, the cortical veins or not, and are those veins dilated, forming a venous lake or not. We have two main broad classifications for the dural fistulae, the Conyard classification and the Borden classification. We'll go very briefly upon those two. The Borden classification is much simplified one, which type 1 Borden classification, just an antegrade drainage in the dural sinus. Type 2, antegrade drainage with a retrograde drainage into the cortical veins. Type 3, it's an isolated cortical veins drainage with or without ectasia, and it can have perimedullary veins with it. A more complicated Conyard classification. Type 1, there's an antegrade flow in the sinus. Type 2A, there's the reflux in the secondary veins. 2B, reflux in the cortical veins only. 2A and B, there is reflux in both the secondary and the cortical veins. Type 3, there is isolated cortical venous drainage without ectasia. Type 4, there is ectasia in the cortical veins. Type 5, it's drainage into the spinal perimedullary veins. This one collects the two classifications together. As you can see in the first picture, there is antegrade flow without any cortical venous reflux. This puts us in a Borden type 1, Conyard type 1 classification. The second image, There is reflux in the secondary veins without any cortical venous reflux with an antegrade flow, also in a Bourdain type 1, Conyer type 2A. The third image, you have reflux in the cortical veins with an antegrade flow. This is Bourdain type 2, Conyer type 2B. The third one, here you have only secondary reflux and the cortical venous reflux without antegrade flow. This is Bourdain type 2, Conyer 2A plus B. Now just isolated cortical venous reflux without ectasia, Bourdain type 3, Conyer 3. Here you can see venous ectasia, Conyer type 4, and here is the spinal veins, Conyer type 5. This is a Bourdain type 1 classification. There is a transverse sigmoid sinus fistula with an antegrade flow in the sinus, and you cannot see here any cortical venous drainage. Here is a type 2, as you can see, the cortical vein, but there's still flow in the sinus. Here is type 3, there's only cortical venous drainage. The clinical features of the dural fistula varies dramatically from being asymptomatic to just having some benign symptoms like pulsatile tinnitus and headache, and aggressive symptoms can reach us up to intracranial hemorrhage. We have to predict the aggressive symptoms. We have to assess the venous drainage and the location itself. For the venous drainage, it's more aggressive if you have a leptomeningeal venous drainage, if you have an aneurysmal venous dilatation, or galenic drainage, or there is a stenosis or occlusion of the associated venous sinuses. For the location, the tentorial and the anterior cranial fossa tends to be more aggressive and holds more aggressive symptoms. We'll show a more detailed classification for the symptoms according to the location. As you can see, the cavernous sinus usually presented by ocular manifestations, the transverse sigmoid and the superior sagittal sinus usually presented by headache, the tentorial dural fistulae usually presented by Berwick and tinnitus, and the anterior cranial fossa usually presented with intracranial hemorrhage. The overall risk of hemorrhage of the dural fistula is 1.6%, carrying a very wide range of morbidity and mortality, 1.8% to 20% per year, with a 35% risk of rebleeding within the first 2 weeks. The benign dural fistulae spontaneously thrombose after angiography or compression and may not need any further treatment. The treatment option that we have, we can observe just the benign symptoms, mainly type 1. We can do a transarterial embolization, which is a favorable treatment in the less aggressive lesions, or the transvenous embolization, which can be resorted to the more aggressive lesions, but this can only be done after doing a proper DSA to see if this involved sinus, you have to make sure that it's not used by the brain, or is there an alternate pathway for this venous drainage. When should we treat the dural fistulae? The key point here is the venous drainage. We have to assess perfectly your venous drainage. You have to appreciate the neurological risk for the patient and define your strategy before approaching the patient. As we said, the lesser grades or the benign types, we can just observe the patient and do a series of follow-ups. The more advanced or the more aggressive lesions, will definitely go through and treat the patient. To cure this patient, you have to occlude the primary draining vein, either from the anterior arterial side with an antegrade navigation or a retrograde navigation through the veins. Type 1 dural fistulae, there is usually no neurological risk. So you don't have to take any therapeutic risk into treating this patient. We only treat this patient if the symptoms are not tolerated by the patient anymore, if there is intracranial hypertension, or is there any risk of transformation for more aggressive type. If you do a DSA and you find venous stenosis, this can give us an indication that it can transform to a more aggressive type. Upon treating a type 1 dural fistula, you have to do it without any risk because it's already a benign etiology. You have to do with a transarterial approach and preserve the sinusy of the patency of the sinus. The type 2A, there's a risk of intracranial hemorrhage if the patient has papillary edema, or there is a visual loss, or there is always risk of venous dementia. Again, it's more or less a benign type, so we have to do it with a transarterial approach and preserve the sinus patency. the aim here maybe not to totally cure the patient, but just reducing the flow inside the fistula can be enough to improve the symptoms for this patient. For the more aggressive types, there is a very high risk of hemorrhage and venous infarction, and those fistulae must be cured. As you can see here, there's a type 5 fistula with a spinal venous reflux causing progressive myelopathy. Type 3 and 4s, the transarterial is the first line for treatment. Transvenous can be done if it's not too risky, and there's the most important thing, avoid occlusion distal to the foot of the vein. Just a very quick summary for the treatments. So if we have no cortical venous reflux, which is Borden type 1, Conyer type 1 and 2A, if the patient is asymptomatic or can tolerate his symptoms, just observe this patient. If there's no changes in the symptoms, we can do serial follow-ups with MRA. If there's improvement or the worsening of the symptoms, you have to repeat the angiogram. If the patient cannot tolerate the symptoms, we have to go for a palliative treatment. Here we can do endovascular transarterial embolization of the feeders. For Borden type 2, Conyer type 2B or 2A and B, if there is no neurological deficit, you have to assess the venous phase with a proper DSA. If the sinus is not used by the patient, we can do complete obliteration or excision of the lesion, including sacrificing the sinus, or just we can do cortical venous reflux disconnection. If this sinus is used of the vein, you cannot risk to sacrifice the sinus. You have only disconnect the cortical venous reflux. If there's neurological deficits, if there's any neurological deficit secondary to the venous congestion, you have only to interrupt the feeding arteries and avoid getting near the veins. For Borden type 3, 4 and 5, if there's no neurological deficit, again, assess the venous phase. If there's reflux in the cortical vein, which is not used for drainage of the brain, CVR disconnection. If there's used by the brain, just interruption of the arterial feeders. And if there is neurological deficit, we have to do just interruption of the feeding arteries. Our take-home message here is upon dealing with the dural venous fistula, you have to really assess the anatomy quite well before trying to approach the dural fistula, and you have to do a very proper angiogram and assess the sinus, assess your venous drainage, because this is the most important factor upon treating the dural fistula. Thank you.
نشكر دكتور أحمد أبو الهدى على ال very impressive talk. حد عنده أي أسئلة؟ خلي الأسئلة للآخر. ودلوقتي معلش هنروح